our patients after major critical abdominal injuries has never been used. Usually they associate with one or more complications that will affect modality, mobility, length of hospital stay, they have length of rehabilitation. So just controlling hemorrhage may not be good enough to make sure that patients are going to survive. So, my task is to discuss some post-operative complications after laparotomy and risk factors associated with and any measures that we can do to reduce the impact of these complications to get the good outcome. So what are the common complications after trauma laparotomy? Development of intra-abdominal hypertension leading to the abdominal compartment syndrome requiring open abdomen, and abdominal sepsis, bowel obstructions, wound lesions, acute kidney injury, acute respiratory distress syndrome are some common complications. I will present you some case scenarios just to highlight the development of these complications. So, this patient, young chap, fell from a scaffolding onto a mammoth. He got impaled injury with the handle of the mammoth through the perineum, abdomen, liver into the right hemisphere. Patient was taken to for emergency laparotomy and the handle was removed. There was a liver injury, contained liver injury was cracked, and the eccentric gas was repaired and bleeding controlled, sent for ICU observation. During the second laparotomy, it was noted that bowel was ischemic, right hemicolectomy and hyostomy was created. Then again patient returned to ICU. Post-operatively, patient developed abdominal compartment syndrome. Therefore, we have to manage as an open abdomen. And post-operative cause was significantly having sepsis, abdominal sepsis, protracted fever spikes, not responding. So, had to undergo multiple laparotomies and washouts, drainage of collections to deal with the septic focus. And not only that, patient developed ARDS and low pneumonia as well, and patient developed acute kidney injury and had to undergo dialysis. Ultimately, with the good support from the intensive care team, we got the infection control, and then we drafted the open abdomen with the help of plastic surgeon and third cover. Patient was discharged nearly 3 months after the admission. And in this next case, 31-year-old male, motorbike rider collided against the wall, had the right side at multiple rib fractures with moderate pneumothorax and grade 4 liver injury. Patient was severely unstable on admission and taken for emergency laparotomy after resuscitation. Liver was packed and sent to the ICU. Patient was recovering well after the back removal, bleeding control, until day 7. Patient developed abdominal sepsis on day 7 and had to do laparotomy. There we found large amount of BDS content with the infected fluid. So it was drained, washed out, and post-operatively this patient also developed abdominal compartment syndrome, so had to manage as an open abdomen. And Few days later, patient developed intestinal obstruction due to the adhesions. It was not settling with the conservative management, so this was done to relieve some bowel loops. And later, patient managed the negative pressure social assistance device, and patient developed interstitial. Then he started having significant problem. We were not wondering whether this patient is going to survive because frequent hypotension, sepsis, electrolyte imbalance. Somehow we got sepsis control, and intervenous fistula was excised, and patient was sent home again after 3 months. So the fistula and this patient will go going home. So sepsis and acute compartment syndrome has been common after trauma laparotomies. So I will touch these topics mainly because of the time constraint. Abdominal sepsis. What are the risk factors for development of abdominal sepsis after trauma laparotomy? Interval between the trauma and the surgery. Higher the injury severity score, more chance of getting infection, trauma ICU stay, and more associated injuries, number of blood transfusion types, and intraoperative hypertension. All these positively correlate with the development of abdominal sepsis. And what causes abdominal sepsis? Mainly the contamination comes from the GI contents during procedures, and penetrating injuries, contaminated abdomen, open and contaminated wounds in the patient, emergency laparotomy. We are saying it is not always sterile procedures when broken. Hypothermia, hypoperfusion, central lines, all adding to the development of sepsis. So, what can we do to reduce the impact of this sepsis? We may not be able to prevent or prevent, but we can reduce the impact. So, have a high degree of suspicion of development of sepsis, all these cases, and monitor carefully white cell count, CRP, and the fever chart, temperature, pulse rate. So, don't take just one value, look for the trend. Increasing trend, and then look for the cause. If there is a clinical deterioration, always look for the cause. And there should be low threshold to explore the suspected focus of infection. Clinical features usually sufficient to take decision to explore, not necessarily to all the time wait for the CT abdomen or CT confirmation showing some collection or analysis. Minimize contamination to spillage during your procedures, and particularly in liver injury. Look for the possibility of bile collections. And when you are doing abdominal packing or damage control procedures, try to do the second loop laparotomy early, within 24 to 48 hours. The more you delay, the increased chance of infection. And starting the enteral nutrition early helps to reduce the development of sepsis. And not only that, your surgical techniques also matters in controlling use of disinfection, wound proper debridement, profuse irrigations, and adequate use of blades, appropriate caution, prophylactic antibiotics in adequate doses, repeating when the resuscitation volume increases, blood transfusion increases, and the surgical procedure Usually, this critical the patient after laparotomy we keep in ICU, and ICU is not a very good environment. There are so many nosocomial infections contributing to sepsis. Therefore, the staff should adhere to strict infection control practices to prevent ventilator-associated pneumonia, UTI, catheter-related infection, some multi-drug resistant infection, particularly Acinetobacter. So, very good practice of infection control is needed. Right. So, the next complication is development of intraabdominal hypertension leading to abdominal compartment syndrome. We say there is a abdominal compartment syndrome, there is a sustained pressure more than 20 mercury of millimeter with associated middle organ dysfunction. What are the risk factors? Large volume resuscitation, massive transfusion protocol use, IDS, for hypothermia, coagulopathy requiring hormonal therapy, severe sepsis and septic shock, critical illness necessitating of cirrhosis, and mechanical ventilation and peak more than 10. So those features. And particularly when the packing is done, there will be venous congestion to the mesentery and the bowel ischemia. When the resuscitation begins, there will be reperfusion, there will be pre-radical damage to the mucosa and increased permeability, so the bowel will be massive. That gives rise to the intestinal hypertension and development of compartment syndrome. So, what are the non-surgical strategies you can follow to reduce the intraabdominal hypertension? Inductive suction, rectal decompression. You can reduce the interval feeding with propionate drugs and enemas can be used to reduce the drug content. Sometimes they give it bronchoscopic decompression. Epidural anesthesia is shown in some studies to reduce the abdominal pressure. Percutaneous drainage of abdominal collections and hypertonic and following resuscitation. So, these factors not proven in controlled trials, but there are some theoretical benefits of using these methods. So, if you diagnose, if you suspect and early detect by frequently monitoring, the treatment is expedient deep decompression. We were going back to the open abdomen, so then there will be success rate of reversing the organ dysfunction and overall survival will be 59. Open abdomen is not without problem. It can cause more complications. It can increase the chance of infection and the fistula formation and increases the need for abdominal or reconstruction. So, try to cause open abdomen early. Sometimes if you fail, you have to resort to the keeping open abdomen later during grafting options. But you can try at least within a week whether you can close that. So, what are the predictors of failure of primary erosion? Number of re-exploration, intraabdominal infection, bloodstream infections, and acute renal failure, intermittent fistula, and high injury severity. These factors may predict possibility of failure of primary position. So, in summary, there may be multiple post-acute complications occurring in a trauma patient, so be vigilant, expect those things, and monitor them for development, going through the parameters. If there are risk factors, try to detect early and initiate treatment early.